So welcome to my channel USMLE questions by VCMD. USMLE questions by VCMD. We're going to be reading the first aid, step 1 for USMLE step 1 United States medical license exam. This is the edition 2025. Edition 2025. Just keep in mind that every error is not corrected, so you have to wait for later correction. Let's start with immunology. Immunology. So let's start with immunology, lymphoid structures. So we have two types of organs in lymphoid structures. We have immune system organs that are either grouped in two groups of organs. The first group is the bone marrow, and the thymus. This is the primary organs. So remember, in the bone marrow, you got the V cell maturation and immune cell production. In bone marrow, you get cell production, immune cell production, and B cell maturation. In the thymus, you get a T cells maturation. Remember, thymus for T cells maturation. Bone marrow for B cell maturation. The second group of organs that we have in the immune system organs, it is the spleen, the lymph node, the tonsils, the adenoids, appendix, player patches, and all of them allow the immune cells to interact with antigens. So any antigens, it could be a bacteria, a virus, all of them interact with the immune system in all those organs and spleen and the lymph node and the tonsils and the adenoids, appendix, or patches players. Just a reminder that Peyer's patches are small oval shaped clusters of lymphoid tissues localized in the small intestine. They played an important role in the immune system by detecting and responding to potential pathogens in the gut. The Peyer patches are typically found in the ileum, the last part of the small intestine. They consist of small follicles that are spherical clusters of immune cells. The follicles are surrounded by a thin layer of connective tissue and covered by specialized epithelial cells, microfold, or M cells. The clinical significance of this is that the Peyer's patches can be involved in certain immune disorders such as Crohn's disease and ulcerative colitis. In these conditions, the immune system overreacts to antigens in the gut, leading to inflammations and damage. The Peyer patches can also be target for certain viruses and parasites, such as HIV and rotavirus. So the lymph node as a secondary lymphoid organ that has many afferent, one or more afferent, just one afferent, A with a afferent, and one or more afferent. It is an encapsulated organ with trabecula. The functions are non-specific filtrations by macrophages, circulations B and T cells, and immune response activation. Those are the functions. The functions. The lymph node function is non-specific filtration by macrophages, circulations of B and T cells, and immune response activation. So that's how it looks like. That's a lymph node. Just remember, the follicle is localized in the outer cortex side of the B cells localizations and proliferation. So the B cells are in these areas there, in this area, more external. That's the follicle. You can see here follicle. those little round things here on the external part, this is follicle. They are localized in the cortex. So as the reading say here, localization on the cortex, out cortex, that's the follicle localized in the outer cortex. You can find the B cells. B cells, their localizations and proliferation. So they grow there and they're localized in this part of the follicles. Okay, so the first follicles are dense and quiescent. So that means the first group of follicles are dense and quiescent. That means that they're not producing any metabolism, that they're dormant, they're sleeping. So that's why you look, they are smaller here. The first group of follicle. The second group of follicle, they have pale center, as you can see here, the pale center, and there are germinal centers and very active, and they are very active. Just remember, in the context of the USMLE, the lymph node histology, the lymph node histology, the germinal center is a crucial area within B cell follicles where V cells undergo end proliferation and differentiation and some somatic hypermutation, ultimately leading to the formation of a long-life plasma cells and memory B cells. So the germinal centers is a specialized region with the lymph node where V lymphocytes, the white cells, proliferate and differentiate and mature into antibody production plasma cells. So this is where you have the production of plasma cells. So the germinal centers are typically found in the cortex of the lymph node near to the capsula sinus. They may also be present in other lymphoid organs such as spleen. So the primary function of the germinal centers is to generate high affinity antibodies against a specific antigen. By B lymphocytes in the germinal centers undergo a process called somatic hypermutation, which introduce random mutations into the antibodies genes. This process allows to the selections of B cells that produce antibodies with the highest affinity for the target antigens. So the germinal centers also produce memory B cells, which can quickly respond to the future infections with the same antigen. So if you got an infection and you get the germinal centers, they got like a memory. When you get infected to this same bacteria, they have already created antibodies for that. The vaccines work in the same kind of idea. So the medulla, this one here, consists in a medullary cords, closely packed lymphocytes and plasma cells, and medullary sinus contain reticular cells and macrophages. The medullary tissues communicate with different lymphocytes, communicate with efferent lymphatics. As you can see here, the medullary sinus communicate with the efferent lymphatics. Remember, efferent for exit and efferent for arriving. A of arriving, efferent, and efferent for exit, exit. Do this association so you don't confuse efferent arriving with aid and efferent or with exit, salida, going out, efferent, lymphatic. Remember, that medulla contain macrophages and reticular cells. You can associate medulla M with macrophages, M with N, medulla, macrophages. Remember, follicle with B cells, and then paracortex T cells. So you have to remember this one. Follicle B cells, medulla, macrophagus, and paracortex T cells. You're gonna remember paracortex because you got a T here. Paracortex. Paracortex is the house of T cells. So paracortex contain T cells is the region of cortex between follicles and medulla. Contain high endothelial venules through which T and B cells enter from blood. Underdevelopment in patients with DiGeorge syndrome. So the paracortex with T cells is underdeveloped in patients with DiGeorge syndrome. Remember that one. DiGeorge syndrome. Do you remember what is DiGeorge syndrome? Just remember the paracortex is the T cell rich area of lymph node focalized deep in the cortical layers and surrounding the medulla, where lymphocytes enter the node via high endothelial venules. So here's more detailed explanation. So the paracortex is situated deep in the cortical layer of the lymph node, bordered by the medulla. The cell's composition is the primary population is the T lymphocytes. Remember, the T lymphocytes are CD4 and CD8. CD4 and CD8. Then, remember the function. The function, the paracortex is the key area for T cells interaction with dendritic cells, and is where the blood-borne lymphocytes enter the lymph node through high endothelial venules. So remember in the context of lymph node and USMLE preparation, the paracortex is the thymus-dependent area. We're talking about paracortex, where the T cells live. Is the primary populations by T cells and dendritic cells, where the T cells activations and immune response are initiated. Here's more details and explanation. So the location is paracortex is localized in the inner part of the lymph node cortex. Inner part of the lymph node cortex, surrounding the medulla. The key cells are the T cells and dendritic cells. Remember, paracortex, T cells. The paracortex is the main location of T cells, which are crucial to the cell's maturation immunity. The dendritic cells, those cells present antigen to the T cells in the paracortex, initiating the T cell activation. So the dendritic cells, they come or they bring the antigens or bacteria or virus to the T cells, and they initiate the T cell activation. Remember, as we mentioned before, the high endothelial venules. So in this area, the high endothelial venules are in this area. The high endothelial venules is the paracortex contain specialized blood cells called high endothelial venules, which the T and B cells enter the lymph node. There's other part that say that this is where they enter into the bloodstream. The function is the T cell activations. The paracortex is the site where the naive T cells, that mean the newborn T cells, encounter antigens presented by the dendritic cells, leading to T cell activation and differentiation into the effector cells, that cells who kill, effector cell. So the lymph node surveillance, the paracortex plays a vital role in immunotherapy, in monitoring the lymph for antigens and initiating immune response. And remember DiGeorge syndrome. DiGeorge syndrome is a very well known 22q11.2 deletion syndrome. It is a genetic disorder is a genetic disorder that affects multiple organs and systems. It is caused by the deletion of the small portion of the chromosome 22, specifically the Q11.2 region. So, the George syndrome is a deletion syndrome. It is a genetic disorder that affects multiple organs and systems. It is caused by the deletion of small portion of the chromosome 22. Some symptoms of the George syndrome uh, are heart defect, uh, thymic hypoplasia or aplasia, immune system dysfunction, parathyroid glands dysfunction, facial abnormality. You can have cleft palate, small ears, uh, learning disabilities, behavioral problems like autism or spectrum disorders, and kidney problems and skeletal abnormalities. So the George syndrome is a 22q11 syndrome, previously known as the George syndrome or velocardiofacial syndrome. Velocardiofacial syndrome. It is an immunodeficiency that is caused by a microdeletion of chromosome 22. The George or velocardiofacial syndrome were historically named differently, but are now understood to be phenotypic presentation of the same disorder. So the 22q11 microdeletion lead to a developmental failure of the third and fourth pharyngeal pouches, which include the thymus and parathyroid glands. Patients have thymic aplasia or T cells deficiency, with an increased susceptibility to virals and fungal infection. This is important. This is in all questions you're gonna find this. The George syndrome give you thymic aplasia and T cell deficiency, which increase the susceptibility for virals and fungal infections. Patients also have parathyroid dysplasia and subsequent hypoparathyroidism and hypocalcemia. So you're gonna see calcium low. You're gonna see hypoparathyroidism. You're gonna see recurrent infections, virus and fungal, and diminution of the T cells. And this is a very concern the George syndrome. Other findings include abnormal faces, including cleft palate, cardiac involvement typically include truncus arteriosus and tetralogy of Fallot. So now that we're here, let's keep reading about Shirya-Higashi syndrome. This is thank you to Pixel Rice. You can go now, create your account, and they have it in a free trial. You can log in and you can. This is for pay. I don't know how much they charge you, but it's very visual. If you're a person who learned visual way, is a good platform to learn from. So let's read this from them. Shediac-Higashi syndrome. The Shediac-Higashi syndrome is the autosomal recessive immunodeficiency caused by defect in the linced protein. Let's see what is the linced protein. So he said the linced protein is also known as the lysosomal trafficking regulator. It's a protein involved in the transport of materials into the lysosomes, the cell's recycling centers, and mutations of the lyase gene cause Shediac-Higashi syndrome. So this kind of protein is like a transport. They bring material, they move material away or toward to the lysosomes to be recycled or destroyed or whatever they have to do. So the lyase protein, I would say lyase or least protein, is known as a lysosomal trafficking regulator. It's a protein involved in the transport of materials into the lysosomes, the cell's recycling centers. The mutation of the lyase gene causes Shediac-Higashi syndrome. It's a rare immunodeficiency disorder. It's a rare immunodeficiency disorder. Here's some more details. So the deficit in this list or lysosomal trafficking regulator protein cause problem in vesicle transport, which must significant which much impair phagosome lysosome function. Due to defect in phagocytosis, patients are immunocompromised and present with recurrent pyogenic infection. Remember, pyogenic infection is an infection caused by bacteria that produce pus. Pyogenic bacteria. The most common causes of pyogenic bacteria include Staphylococcus aureus, Staphylococcus pyogenes, Escherichia coli, and Pseudomonas aeruginosa. Those bacteria invade the tissues and release toxins, leading to inflammations and pus formation. Symptoms of pyogenics are, fatigue, chills, fever, pus, discharge, pain and tenderness, redness, swelling. This is pyogenic infection. So, recurrent pyogenic infection. Oldest clinical manifestations include progressive neurologic dysfunctions and albinism. Remember, the melanina can travel to the end where they're going to do the function because the transport protein is not working. So that's why this is why they produce albinism. On blood smear, giant granular are observed in granulocytes and complications that look out for it infiltrative lymphohistiocytosis. Infiltrative lymphohistiocytosis. They are overactive lymphocytes and histiocytes, which resulting in pancytopenia. So now let's do a question for immunology. A 3-year-old girl is brought to the office after developing fever and sore throat. The patient recently entered a daycare, and similar symptoms have been reported in several of the other children. Physical examination saw exudative pharyngitis and enlarged anterior cervical lymph node. A rapid antigen detection test confirmed the diagnosis of Streptococcus throat infection. Her condition developed with antibiotic therapy. The condition resolved with antibiotic therapy. Then, several weeks later, she is re-exposed to Streptococcus pyogenes. The bacteria penetrations beyond the surface epithelium are immediately caused with performed IgG antibodies. Which of the following substances act in the most similar manner to IgG antibodies to facilitate phagocytosis? So in this case, they asking which of the following substances act in the most similar manner, the most similar way like the IgG antibodies to facilitate phagocytosis. In this case, complement is associated with phagocytosis. So I would pick complement. And this is the correct answer, complement. Opsonizations and phagocytosis. Opsonizations occur when a host protein such as immunoglobulin or complement bind to the surface of antigen cells or bacteria in this case to promote phagocytosis. The most important opsonin causing protein are immunoglobulin G and complement C3b, but mannose binding lectin and C-reactive protein can also optimize opsonized cells. Other opsonins are bound to the cell surface. They act as a hostler to receptors and phagocytoses, by example, Fc receptor or C3b receptors, to grasp, allowing the phagocytes to move early, helpful to foreign cells. So just keep in mind, immunoglobulin G and complement C3 are part of the process of phagocytosis. Phagocytosis is had to be related for opsonizations. Opsonizations had to happen before phagocytosis. So opsonizations occur when a protein such as immunoglobulin or complement bind to the foreign cells, such as bacteria or coast force or caught to the surface or to such a bacteria and caught the surface in housing phagocytosis. The most important opsonin are immunoglobulin G and complement C3b. Another question: a 3 years old boy is being evaluated for persistent diarrhea. Though the patient seemed healthy in his 12-month well child visit, and then he has experienced 4 episodes of otitis media and 3 episodes of pneumococcal pneumonia. He was at the 50 percentile for weight and height and 12 month, but now he's in 25 percentile on height and 10 percentile on weight. So he's underdeveloping now. He was okay, but now he's going under. The patient is referred to an upper gastrointestinal endoscopy, and Giardia is isolated from duodenal aspirates. Further workup showed very low serum levels of immunoglobulin types. Flow cytometry of the patient's peripheral blood is most likely to show near absent cells bearing to which of the following markers. So this little boy, the immune system is fading, it's going down. So they're gonna do a flow cytometry in these patients. So peripheral blood is most likely to show near absent or very diminished cells bearing which of the following markers. So which one is going to be low? They're asking you which cell is going to be low in this case. So the answer should be CD19. Yeah, CD19. So these patients, recurrence in pulmonary infections like Giardia lamblia, gastroenteritis, failure to drive or to growth, or failure to develop, and low immunoglobulin levels are suggestive of X-linked agammaglobulinemia. X-linked agammaglobulinemia. X-linked agammaglobulinemia. In this condition, a mutated in the Brodon tyrosine kinase gene causes failure of bone marrow to produce pre-B cells to develop into the mature B cells, a step necessary in the B cells to leave the bone marrow and enter the peripheral circulation. These patients with a X-linked agammaglobulinemia have low or absent B cells in the peripheral blood and lymphoid tissues, and pan-hypogammaglobulinemia. By example, they are very low in immunoglobulin G, M, and A. As of this result, they are in increased risk of infections with pathogenic encapsulated bacteria. Patients also have increased susceptibility to certain virals and parasitic infections, such as in this case Giardia lamblia, due to the absence of opsonization or neutralization antibodies. So remember, as I always said before, for opsonization, we need the immunoglobulin G. In this case, if you don't produce any kind of immunoglobulin, you're gonna have susceptibility of infections in gastrointestinal and parasitic infection. In this case, Giardia lamblia. So flow cytometry can be used to assess the number of circulating B cells by using fluorescent tag that bind to a specific B cell surface protein, such as CD19, CD20, and CD21. Remember, CD19, CD20, and CD21 are the surface protein for B cells. We have to remember this. We read it before. The B cell surface proteins are CD CD19, CD20, and CD21. Every time the USMLE is asking you about B cells, remember the surface proteins are CD19, CD20, and CD21. Another questions about USMLE that they always ask is the CD4 and CD8. Remember, those are surface marker for T cells. T cells. CD4 is for T helper surface marker, and CD8 is for cytotoxic T cell surface marker. Remember, CD4 C helper and CD8 cytotoxic T cell surface marker. Both B cells and T cells can be deficient in patients with certain form of several combined immunodeficiencies. There's another pathology, severe combined immunodeficiency. However, those patients typically have failure to drift, persistent mucosal candidiasis, and severe infections with opportunistic organisms like Pseudomonas, like pneumocystic. I'm sorry, like pneumocystic, no Pseudomonas, pneumocystic. So at a young age, at less than 6 months. The other option was CD15. Remember, CD15 is always useful to find this disease called Hodgkin lymphoma. So CD15 is a cell surface protein present on granulocytes. It's also present on near all the three stem cells and is therefore a cytotoxic marker used for diagnosis of the Hodgkin lymphoma. Another one to remember is CD16, just to discard if you have it in a question. So remember, this is not a good one if they don't ask you about natural killer. So CD16 is a low affinity Fc receptor found on the surface of natural killer cells, the neutrophils and macrophages. This is CD16. CD15, Hodgkin lymphoma. CD4 and CD8, T cells markers, and CD19 and CD20 and 21 is B cells surface markers. Remember, X-linked agammaglobulinemia is characterized by the low or absent circulating B cells 19, 20, and 21, and panhypogammaglobulinemia. So you don't have any immunoglobulinemia. You don't have in your body low or nothing immunoglobulin. You don't have immunoglobulin A or G or M, nothing. Affected patients have increased susceptibility to pathogenic bacteria and their virus Giardia due to the absence of opsonasins and neutralizing antibodies. So let's do this last question. So, 5-year-old child is brought to the emergency department by his parents for right arm pain. The patient reported that he was playing hide and seek outside and felt a sharp pain on his arm while hiding in some thick bushes. So the parents suspect that something had stuck him, like an insect or something. So the physical examination showed an edematous and erythematous plague with a mild central pallor. Residual stinger localized central of the lesion is it's already extracted. The physical examination otherwise is normal. Which of the following substance is most likely develop response? So which of the following substances is most likely directly responsible for the skin finding observed in this patient? So the skin is erythematous, like inflamed. So definitely something is sticking or some insect. So what is the answer? Histamine sound good. Let's see. Yeah, histamine. So let's read. So this child is experiencing a local allergic reaction. It's a type 1 hypersensitivity as an insect sting. The cutaneous findings are consistent with a Welland flare reaction, and erythematous, pale or black often with central pallor and peripheral erythema. Let's see what is that. So that's what would look like a wealth and flare reaction. Wealth and flare reaction. So during the initial allergen exposure, a patient predisposed to allergic response will undergo antibody class switching from immunoglobulin M to immunoglobulin E antibodies, specific for the allergen. The immunoglobulin E produced by B lymphocytes and plasma cells then bind to the high affinity immunoglobulin E Fc factor on basophils and mast cells. The re-exposed to the allergen result in a cross-linking of bound immunoglobulin E antibodies with subsequent degranulations and release of inflammatory mediators by the sample proteases, histamine, leukotrienes, and prostaglandins. So, localized vasodilatations and increased vascular permeability result in the characteristic wealth and flare lesions. In severe cases, widespread release of those agents can cause systemic vasodilatation and bronchoconstriction and massive fluid shifts, leading to anaphylactic shock and potential death. So remember, there's a antibody class switching from immunoglobulin M to immunoglobulin E antibodies specific for allergen. The immunoglobulin E produced by V lymphocytes and plasma cells then bind to the high affinity immunoglobulin E Fc factors and basophilus and mast cell. They re-expose to the allergen result in a cross-linking of bound immunoglobulin E antibodies with subsequent degranulation and release of inflammatory mediators like histamine. This is how it looks like, wealth and flare. Slightly elevated urticaria lesion with wealth and erythema, that's going to be the flare. The wealth and flare lesions usually result from an allergic type 1 hypersensitivity reaction on initial exposure of the antigen, but for example, insect venom promotes antibody class switching and immunoglobulin E. Subsequent exposure promotes cross-linking of immunoglobulin E on basophils and mast cells, resulting in degranulation and release of the multiple vasoactive mediators, including histamine. Thank you very much for this time. See you in the next time. Don't forget to subscribe and hit the like button. Thank you very much, guys. Have good luck and pass your test. Focus and concentrate.